Well, hi, everybody. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'm excited to welcome you all to today's live webinar. And it is hosted by CarePort, which is powered by WellSky. And it is titled How UCSF Health is Improving Patient Outcomes Through Timely Access to High Quality Post-Acute Care. And we're always excited when we have a case study to work with, because this is real life, and this is what really is happening out there. So we're excited to hear from our speaker today. A few items of note before we get started, just some housekeeping. Everyone is joined today in listen-only mode. It's a traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera or anything like that. We can't see you, so don't worry. But we do want to hear from you. And so during the presentation, at any time, you can ask a question, and we're going to have a Q&A time dedicated toward at the end that we can ask your questions. But you don't need to wait until then in order to ask your question. So at any time during the presentation, you can use your attendee module, and there's a little space for questions on there. It's different than the chat. So just make sure you ask your question there, and then we're going to get to as many of those as we can today during the allotted time. If we don't get to yours, we will. Someone will reach out via email afterwards and answer your question. So even if we're just kind of wrapping up at the last minute, you have a question burning, go ahead and ask it, and someone will get back to you. But we're going to get to as many as we can today. Finally, today's session is being recorded, and so what's going to happen is when we're done, you will receive an email from one of us, probably at the VBC Exhibit Hall team, and there will be a link to where you can watch the recording and even share it with colleagues and friends. We hope that you do, and also a place where you can download the slides and learn a little bit more there. So please take advantage of that, and I'll remind you again towards the end. So without further ado, I would like to at this point turn it over to Ms. Kayla Allen, and she is a senior marketing strategist with CarePort, and she's going to introduce our speaker today. So welcome, Kayla.
Hey everyone, thanks for joining us today, taking some time out of your day. I'd like to introduce Missy Metter. She's an innovative leader with 12 years of experience in clinical systems development, case management, and transitional care. She holds a Bachelor of Science in Nursing from Clemson University, a Master of Business Administration and Healthcare Management from the University of Texas, and a Commission for Case Manager certification. As Assistant Director of Post-Acute Care at UCSF Health, she's responsible for overseeing the UCSF High Performing Provider Network, the UCSF Transitional Care Service, and over 25 plus vendor service agreements for the UCSF Care Coordination and Patient Transitions Department. Missy has made significant impact in reducing unnecessary hospitalizations, cutting costs, and promoting quality outcomes for her patients. Missy is well respected among her peers and is recognized as a speaker and thought leader in the healthcare community. She continues to share her expertise and experience with other healthcare leaders so they too can solve complex challenges and drive positive change. So now Missy's going to be sharing a little bit about how she uses CarePort in her day-to-day work, and I will hand it over to you. Thanks, Missy, for joining us.
Great. Thanks, Kayla, for the introduction. Appreciate it. We're going to start off with a poll just so we can get to know the audience a little bit better.
Okay, I am going to pull up the poll here, and you guys, everyone in the audience should see this momentarily on your screen. So take a second to fill it out. If this doesn't apply to you, then go ahead and leave it blank. And we'll give folks a couple seconds for to put your response in. Okay, we still have a couple answers in, so we'll probably give it another 5 seconds or so, and then we'll pull it down. So go ahead and answer if you haven't. Oh, some answers still rolling in. I don't want to cut it off early. Okay, I think we've had enough time, so I'm going to go ahead and close it off here. All right, and then I am going to share the results. And Misty, I don't know if you're able to see these results.
Yeah, looks like Kayla's putting it in the chat for me. So yeah, it looks like we've got 60% that are hospital-based, 30% from ACO, 60, so actually quite a bit more actually from hospital. I think it's 64% from hospital, 14% from ambulatory, and then 16% from post-acute care. Okay, that's great. So it helps me to get to know the audience a little bit so I can sort of tailor the presentation around maybe some of the things that you'd be interested in. Thanks, Kayla. Thanks, Garrett.
All right.
Awesome. Okay. Get rid of that. Okay, so I want to start off with some of the learning objectives here. So I want to describe the San Francisco market and the conditions when we started, some of the foundations of the program, our methods that we used, our outcomes, report the impact of the overall program, and then go to forecast the future of this in the state of the program. So I think it would just really be good to kind of provide a little context for all of you of where we started as a transitional care program. So we're all aware of the pandemic that occurred in 2020. And I think everyone had probably a shared experience of the impact in that everything stopped. We stopped elective procedures. Everybody was focused on, isolation, testing when that became a priority, and then ultimately vaccines. And in the process of reallocating resources, a lot of programs, including our Home Health Collaborative and SNF Collaborative, paused. So the Office of Population Health here at UCSF, they were reallocated for testing, prioritizing urgent visits, and then shifting to a telehealth model of care, which took a lot of resources. So shooting to mid-pandemic, so what was the result of that? So I think a lot of us thought, this was going to be a 2-week thing and we were going to all be back to work. And then we found out pretty quickly that wasn't the case. And, moving months into the pandemic and even a year or so, we found that our emergency rooms started to become overwhelmed. There were growing healthcare disparities amongst people of color, just poverty, homelessness, underfunded Medi-Cal or Medicaid if you're in another state. And then the folks who didn't necessarily have access to technology. That was a big one for us, is that a lot of our patients, especially our underfunded, just didn't have the ability to connect for telehealth visits, and you couldn't come into visits anymore, and they weren't doing home visits for a while, and it was really impactful to that population, and we saw they were coming into the emergency room more. We also saw that with regulations and testing, there was an impact. Admissions were impacted. We had testing and isolation requirements. And for those of you that work in post-acute care, I think you probably remember with the SNF regulations for isolation, and 1 minute you would be discharging your patient and then you would get a call and they were completely shut down because they had a positive case or several cases. And it was just every day, it was constantly changing. Visitor restrictions were really impactful for those that needed to come and see their family members. Even if they weren't here for COVID, they couldn't come and see their families. And it was really, it was hard for bedside teachers. It was hard because they wanted to be there as a support. And so everything had to be done over the phone or by Zoom or, other conferencing systems. Another big impact was office space and remote work. A lot of healthcare professionals in case management and social work were shifted to offsite. These were positions that may have never been before offsite. And, I clearly have a memory when I was the assistant director of case management during this time, getting a call and saying that all of my staff that were 100% on-site had to be off-site within a week. They didn't have cell phones, they didn't have laptops, we had to figure it out. And we got really creative with the resources we had, but it was tough. And not to mention the staffing shortages, which I think still are a problem, actually. The aftermath of the pandemic have been really problematic for the healthcare system. We have healthcare workers still leaving the profession. In the midst of the pandemic, there were a lot of leave of absences related to COVID. And so operationally, it was really tough to kind of keep things going. And then just over time, just the increased stress and burnout that occurred as a result. So as a result of all of that, our organization said, wow, we need to do something different here. This isn't working. And so we founded the Transitional Care Program as a result. And so It started off as just myself, and I really wanted to align everything with a set of vision and goals that would carry out across the whole lifetime of the program. And I wanted to make sure that the vision and goals were in alignment with my organizational vision and goals as well, because I had an idea that from a strategic point of view, it would make sense and I would get more assistance and resources if I could align with other departments within my organization. And so the vision of the program was to promote better health outcomes for UCSF patients by increasing timely access to high quality of care. But, you know, while I mentioned UCSF specifically here, you know, we are in a community and anything we do here is going to impact our community. So I was really looking out for the better outcomes for our overall community. Our goals were to improve patient outcomes through timely access to care, streamline workflows and align best practices, reduce healthcare disparities, including our Medi-Cal and underfunded patients, and all in an attempt to just bridge the gaps in care that we saw before the pandemic and during the pandemic. And then obviously tying a metric back to just decreasing unnecessary ED and hospitalization utilization. So this is a slide that I actually think is kind of cool because when I started the program, you know, I was told like, you know, you have about 1.5 years to launch this. You need to get yourself organized and you need to come up with a plan that we can bring back to our executive sponsors. So I quickly just put together this timeline and I said, this is what I want to happen. And these are the things I think that I need to do to be able to make that happen and to meet the goals that I want to meet. And so you can see in the first swim lane, this is kind of our foundation of the program. You know, it starts with developing those action plans and goals and visions, and then looking at best practices, hiring staff, developing job descriptions for them, coming up with standardized work and documentation, building out a PAC report framework, so post-acute care network, and trying to figure out where the gaps are and where do we need to focus. And then identifying what those performance metrics are, accessing and developing reporting tools to help me keep us on track, and then review the current agreements and partnerships so we're not reinventing a wheel. How can we modify what we have before we go and seek something else? You know, market research and who are the partners that I want to identify and focus my efforts on trying to get them into our network, and then finalizing contracts, expanding the network, and just over time building those relationships. So in this slide, this is the methods, but I break it down into kind of 3 main buckets because that's how I sort of think about this work, is that there's an overall transitional care program, but you know, there's distinct areas and there's a lot of overlap between them, but I kind of think them as distinct work. So there's complex case management, the post-acute partnership, and then inter-organizational relationships and building that we have to do. I'll just minimize this here. And so for the complex case management program, and if you remember back in the timeline, I kind of referenced hiring a case manager and a social worker. So this was really to kind of build out this program because I needed staff to help support the work that we were doing. And so I knew that I wanted it to be transitional, meaning they were going to start inpatient and they were going to be followed in an outpatient setting. And I also wanted to take the lessons learned from our team and our caseload and then apply it across the house. And so that's what we did here. We have an outpatient work group and we have inpatients that are supported by myself and a nurse case manager and a social worker. The outpatients are community-based support for adults that have 2 or more comorbidities. They're high risk for hospitalization and they have no identified support systems. That's how we identify that population, and that's how we seek those patients inpatient to build our caseload. What we decided early on is that we wanted to be different and unique from inpatient case management. We wanted to provide a value that wasn't already provided by another service. And so what we said is, you know, they're focused on a lot of the skilled services that, you know, when you're immediately leaving the hospital, let's do something a little different that's going to be more supportive to that patient in the outpatient setting. And so instead of focus on what the provider wants, let's reach out to the patient and see what they want. So we identified 3 goals at a minimum that were patient specific. So every time we took a case, we made sure to identify those goals early on so they would help keep us on track. Not to mention it helps determine when that patient's going to be appropriate to discharge as well. The inpatients that we saw were predominantly hospital medicine, and these were outlier patients. So these are complex cases that are difficult to discharge or have low support systems or no income, really difficult to maintain out in the community. And so we would provide consult services for those patients based on the lessons we learned from our outpatients. And so kind of combining all of that in a whole, what we did is, and for outpatients, inpatients, we've been maintaining just over 20 patients. But we meet weekly and do a multidisciplinary huddle for our inpatients and outpatients, as well as the patients that we're following on the consult service. We standardize our documentation and use templates. So any provider logging into a patient's EHR, they see that we're being tracked, that we're consulting because they can specifically see our consult notes. And for our outpatients, we actually have a way to tag them in Epic so that you can see if they're followed by our service and quick notes on where to look in the chart for certain information. So moving into the post-acute partnership, we started off with 9 post-acute agencies and facilities. It's predominantly SNF, home health, and DME. We developed a service line agreement for them that's not financial, but specific to key quality metrics. And so some of those metrics outlined here are 30-day unplanned readmissions, Medi-Cal acceptance rates, and star ratings. We use CarePort Insight Analytics to help us track those metrics, and I develop a dashboard based on those analytics that I share with the members on a monthly basis. Another way to sort of ensure that there's an awareness of who is in our network, we list those members in CarePort Guide as in our network, so the case managers can sort by them. So when they're creating those patient lists, the patients can, in their demographic and by the payer, they can see on that list which ones are in our network and which ones aren't. And then there's other quality data as well, star ratings that and other information that patients and caregivers can use to make their decision. As part of this partnership, we host conferences and in-services at least quarterly. I try to schedule throughout the year based on availability of speakers, also some other educational resources, and I try to tie them in with some of the education that I'm doing in-house for case management. It's an opportunity to network together, as well as providing just, a common space for us to come and learn together. And then all of this is managed by the same staff that manage the complex case management program. So we're a small team and we do it all. The intra-organizational partnerships, we're really kind of launching into this year now that we've got some foundations established. And really the idea here is just to align our goals and strategies, like I said before, with the organization. And so when I selected the PAC members, I made sure that I covered the affiliate service area for UCSF, because I wanted to make sure that just because that patient was in Walnut Creek, which is in the East Bay of San Francisco, that they would have the same access to high quality services as someone in San Francisco or someone in San Mateo. We created a wiki page for our department. And in that, I update policy changes, the PAC contacts, community programs, anything that we did lunch and learns on will be loaded on our wiki page. And then we specifically target the lunch and learns around programs that were kind of up and coming, that were important for long-term care linkage, as well as in-house. The augmented alternative communication was something I was proud of. We created to kind of teach case managers and social workers what communication tools existed for those patients of ours that were nonverbal. So looking at now the outcomes of each of these programs. So this is specific to the complex case management program. And you can see here that with our outpatients, we have had significant reductions in hospitalizations and ED visits, 85 for hospitalizations, 92 for ED visits. And those patient-specific outcome goals that I was talking about, of the 3 minimum for each patient, we've been able to achieve 90% of those patient-specific goals. So that's really impactful for the patient's quality of life. And these metrics were measured 6 months following enrollment. So we look 6 months before enrollment, 6 months after, and we see what improvements we've made. For our inpatient consult services, these are predominantly our hospital medicine outliers. We reduced their length of stay index from 5.22 in FY22 to 4.62 in FY23 for year to date. And that takes us, I believe, through April. And I also wanted just to kind of show some qualitative stuff, because honestly, you know, the reductions and readmissions and of course reducing length of stay are always important, but really why do we show up to work every day is to help people. And so it's really good to see that we're making a positive impact on people's lives. So I've included some quotes here. The first quote here is from a primary care physician from UCSF that helped us for a patient for almost a year. Lincoln, he was homeless and was being assaulted in the community, disabled, and we were able to get him housing and off the street. She was a great partner to work with to help us with that. A couple like messages of just thank yous that we saw. And then the gentleman in the corner here was someone I actually followed at medical respite and provided wound care supplies, and he's now actually come out of that and is helping other patients on the streets kick their fentanyl addiction. So really proud of him and how far he's come. So post-acute partnership quantitative metrics. So this is looking at Q1 and Q2 of FY22 compared to FY23. So like I did that to account for seasonality. And so you can see for the SNF unplanned readmissions, we had a decrease of 8%. The home health, we had a decrease of 5%. Our Medi-Cal acceptance rates for home health jumped by 7%. And the SNF, unfortunately, the SNF Medi-Cal acceptance rates have dropped by 2%, but that was just in the last quarter of FY23. We noticed that our referral volume for Medi-Cal patients for the SNFs have bumped by 200%. So a lot of work there, I think, to increase their managed care network as a result of CalAIM to help improve those numbers. Our average CMS star rating for our post-acute partners is 4.5 to 5%, so we're proud of that. And when you look at the qualitative information here, you can see that really the value I think that that I hear from the post-acute members that I feel like they at least find to be the most valuable is the post-discharge assistance that my team offers. So we will, there's order clarifications that need to happen or updates. We need to add nursing to the home health order. For instance, the PT got in and they said, wow, the medications look like they need someone to look at. We'll jump on an email and get the provider to order those. We'll schedule appointments and transportation for those patients having difficulty making those appointments. We even have our transitional care medical directors help with provider communication, providing feedback on readmissions, offering advice on how, you know, potentially how to avoid coming to the ED, some of the things that they might be able to do, and helping connect provider to provider. And then sometimes it's just customer service recovery. A patient had a bad experience with one of our members, I'll reach out to them personally, get the feedback, and we try to correct it as soon as possible. We also really, one of the things I focused on in the beginning was expanding their network of insurers. And so a lot of the high volume managed Medi-Cal plans in San Francisco County, I reached out to them and I provided an in-service about our program and what we were doing, and just try to advocate for them to expand their network to include our members. And then just community partnerships in general. How can we get not necessarily members in our partnership, but sort of adjunct members to come to our meetings and provide support as well, and get to know everyone. So some of the feedback that we got from some of our conferences is they really liked our speakers, they liked the information, they felt that it was organized and interactive. You know, and one of the things I wanted to do is that I wanted to keep the conferences organized but informal, meaning that I wanted people to talk and network and feel comfortable and not feel like they were just being talked to. So I think that that's had a great impact. So inter-organizational partnerships, instead of giving you a bunch of bullet points, I thought it would be cool to show you some visuals. And so one of the things I'm proud of is the Preparing for Discharge brochure that was created. And so this is a guide that's provided to inpatients, outpatients, patients being registered to the hospital. Just a quick guide of what to expect when they're admitted, things they need to think about, transportation, who can they talk to, a link to the case management website, a number to the case management department in case they want to call and get some information ahead of time. And then I even list out kind of the more common services that you would need after discharge with a quick summary about what those are and how do you qualify for those things. Because some of the information that I got from patients when I would interview them is that they felt like they didn't really understand why they couldn't access an acute rehab versus a SNF, and they didn't understand that quality, that reimbursement issues and level of care. And you know, when you're in the hospital and you've just had surgery, that's the last thing you want to hear. And so they could take an opportunity before they would get admitted to educate themselves on the level of care and the criteria. And then this is just a quick snapshot of our wiki page, and you can see like the child pages that exist with different waiver programs, CHA links. One of the things that my team assists with is LPS and probate conservatorships, and so there's a lot of information about that. This is just a little snapshot of that augmented alternative communication a presentation that I did for case management social work. And then onto the far right is just a snapshot of our service area for the affiliate map. So just the impact of the overall program currently. So like I said, we manage 20 patients on our complex case management program. We started an inpatient consult service for medically active patients with limited support. And we also evaluate patients for medical probate and LPS conservatorship. And if they meet the criteria for that, and there's not alternatives that we could use, and it's the least restrictive, we'll assist with that from helping file petitions and referrals to the various counties. In addition to that, we continue to host the quarterly in-services for within our organization and for the PAC members, community members as well, trying to pull in as many resources and supports as possible. An example of that is we created a in-service for LPS conservatorships that was really intended to be in-house, and it was a kind of a guide for us to make sure that like we were organized and there was some streamlined standard work. And we got some outreach from some of the local outpatient intensive case management programs who said, we want to know more about this. And we were told by the county, you guys have this nailed. So we were surprised by that, but it was great. We were able to share best practices with them as well. And so we kind of pride on ourselves on being a resource to the community as well as our organization. So talking about future state, I want to grow our complex case management program to 30 plus patients. I think we can do that with our current team. And with the post-acute partnerships, really looking to expand to LTAC and home infusion in this next fiscal year. I think the idea behind the post-acute partnership was to create a community of post-acute members that could partner together to collaborate to ensure that the patient has this smooth transition, whether they come from the hospital, they go to SNF or acute rehab, and then eventually LTAC, and that those LTAC case managers and social workers and providers have the ability to access high quality SNFs or home health companies and maybe eventually home infusion companies. And so we don't lose that continuity of care just because they go to a different facility. For inter-organizational partnerships, we developed as part of the transitional care program, and this includes the medical directors for transitional care, a post-acute strategy steering committee. that was actually started this last quarter. We had our first kickoff meeting, and it involved case management and social work, everybody involved in patient transitions, Office of Population Health, ambulatory care, inpatient services, and strategy. And what we said as part of this kickoff is like, we're completely siloed. Sometimes we're doing the same work. And it would be great to really understand and create some transparency around that, so that not only we can just be aware of one another, but we can work together better and not necessarily duplicate efforts. And we can potentially even reassign resources as necessary. So I'll pause here for our Q&A.
Sorry, on mute. So we have a few questions that came in. The first one I'm going to ask is, can you give some examples of the 3 patient goals you used?
Yeah, so commonly what we find, patients don't have access to income, so we're helping them we actually go with them to Social Security to apply for income or benefits. Another one is meal delivery services. We have patients that have new chronic illnesses and they don't know how to manage their diet, and they're having to deal with all of these other things going on. And so there's meal delivery services outside of Meals on Wheels that actually will develop meal plans specific for heart failure, kidney disease, and getting them linked for those services. Sometimes we're getting them IDs even. These patients don't have IDs to be able to get to these services. So those are the more common ones that we do. We also do typical case management linkage. So home health, DME, home infusion, going to PCP appointments, sometimes linking them to new PCP. Recently, we've been doing behavioral health linkage as well. So we'll connect them to a PCP initially, but with the idea that they'll transition some of their behavioral health medication management to an NP or a psychiatrist.
Okay, we have another question that came in. This is a great question. How did you select your SNF network, and how do you keep them engaged in your goals?
Yeah, it's a good question. So when we did our market research, we used CarePort analytics to help us look at our overall market and select like who were seeing the highest volume of our patients, who of those had high quality scores, what were their readmissions rates, what were the current metrics that we were going to hold them accountable for in the SLA, and how are they performing now? And we've created scorecards for our top SNFs. And then we did outreach to inpatients and outpatient care coordinators to poll like what their experience was. And then we did interviews of each of those facilities, and that's how we selected them. And then how do you keep them engaged? Honestly, it's finding what value add you can offer to them. I think the post-acute discharge assistance is huge. I think having them tagged in CarePort as a PAC member helps. We have in that discharge brochure, we include an insert with all of our PAC partnerships as well. And so it just creates some like that we're proud of this network and that we're willing to share it with patients and caregivers and other providers.
Okay, so let's see. Next question we have is from the same individual, actually. Does your team interact with SNF and inpatient physicians?
We do. You know, I was really nervous when we kicked off about, well, I was aware that we could create redundancies. And so I made it really clear to define a specific scope for my team that was separate from the inpatient teams. And we shared that scope with the inpatient team. So we kind of knew where they began and ended and where we started. And I think that that was really helpful. I think by creating the consult service, we have very specific tasks that we do by going to huddles, offering resources, doing assessments on patients in certain situations, but then signing out and going back to that team. And so we provide a very specific service that they may not necessarily have the expertise for or may not necessarily have the time for, and it's been working really well.
Okay, we have another question. Let's see. How does your complex case management program interface with inpatient case management and social work, and how do you avoid redundancy?
I may have just answered that one.
Sorry.
Yeah.
Sorry.
That's okay.
We've got a few more. How do you ensure that patients have a choice of PAC providers, including those in your partnership?
Yeah, so the great thing about CarePort Guide is that we have the ability to share patients' lists with them, print out text, email, and so we can quickly sort based on the patient's demographics, you know, a list of providers in their areas. And in those lists, it includes our PAC members, but also includes other agencies and facilities as well. And it includes the quality metrics that CMS requires us to provide to patients. So they can see for themselves that our members are of the highest quality, and they have the option to select other members, but we provide them as much information as possible so that they can make an informed decision.
Okay. Sorry, I'm going in and out here, so I hope I didn't miss too much, but another question came in, and the question is about how this has impacted your relationships with health plans.
Yeah, I think it actually has been good, because I think the health plans that I've interacted with, especially when I mentioned that I was kind of going out and seeking them and letting them know about our program, I think they were really impressed with what we were doing. And I think it takes a little bit of the burden off of them of ensuring that their members have access to high quality care when the health systems are doing it as well, that we can partner together to ensure that their members have good access. And so it was really well received. And we were actually able to expand a lot of the networks for our PAC members as a result. So not only were they impressed, but they took action, and they actually would add them to their network if they weren't already included.
Oh, awesome. Okay. I think we may be going back a little bit to the topic we were just touching on, but with your SLA, what's your promise to them, to the SNFs, in return for their commitment?
Yeah, so the expectations on our side, so in our SLA, we have what is the expectation of UCSF Health versus them. And we have to ensure access to resources and education, that post-discharge assistance, like I talked about, is all outlined there in expectations. And so I hold them accountable to their metrics and for their attendance and participation. And then they hold me accountable for ensuring that I'm reducing the barriers for them to be able to succeed.
Okay, I like this question a lot, actually. What do you do in areas of the city that don't have a high quality SNFs available?
Yeah, I mean, I think fortunately and unfortunately, depending on how you look at it, because we have such a huge affiliate map, we can send them wherever the services are. That sometimes can pose a barrier to underserved families that may not have cars, for instance. And so we offer, and for those families, like Lyft services to be able to get to their family members for visits and things like that. So we understand that the services may not be where they're at for SNF locations. We're very fortunate that we have a pretty robust home health service area, so every part of the city is covered. It's not an issue. But for those underserved patients, we try to we go and visit them where they're at, so they don't need to worry about that. And then if their family members need to go and visit, we can help assist with that as well.
Awesome. I believe that is all the questions. Does anyone else have any questions? I have time for maybe one or two more. Okay, I believe that's it then. Well, thank you, Misty.
Thank you.
All right. Well, this was great. We had a lot of great audience interaction. Again, if you do have a question and you'd like to submit it kind of last minute here before we close out, please go ahead and do that. And if we don't get to it right now, we'll make sure to answer it, and someone will get back in touch with you shortly via email. But I wanted to thank our speaker today, Misty. Again, thank you so much for this presentation. This was wonderful. As we close out, a couple things. I was going to see if I could get you all to head over to the VBC exhibit hall and check out the CarePort booth that we have over there, there's a virtual exhibit booth that they have there, and we'll have a link directly to it in the slides. But if you go to bbcexhibithall.com, and you can find it there. There's also a lot of great other materials, and that's also where we're going to have the webinar today archived, so you could watch it later. But I will be sending it out to everyone by a link later on today, so you should receive that. It's also where you can download the slides. But again, check out this this virtual booth here. It's got a lot of cool materials there for you. And then finally, if you would like to reach out to our speaker or to the CarePort team, you can do so here. You can see the contact information is on this final slide. And again, this will be on the slides that we provide. Or you can feel free to reach out to me directly, and I'm happy to facilitate an introduction for you. So thank you again so much for spending your afternoon with us. Thank you again, Misty. Thank you, Kayla. And hope you all have a wonderful rest of your afternoons. Thanks so much. Bye-bye.